Hi everyone, I am Ellen Gowda. Today I am presenting seminar on topic multiple myeloma and Hodgkin lymphoma, hematological malignancies. Seminar overview. Today we explore two distinct yet significant hematological neoplasms. While one involves the terminal differentiation of B cells into plasma cells, the other is characterized by unique inflammatory background harboring neoplastic giant cells, morphological hallmarks, pathogenetic drivers, gross organ involvement. Plasma cell myeloma. Clonal proliferation of malignant plasma cells in the bone marrow. Hodgkin lymphoma is the B cell derived malignancy with Reed-Steinberg cells. Multiple myeloma. Multiple myeloma is a multifocal malignant proliferation of plasma cells derived from single clone. It leads to production of monoclonal protein, multifocal osseous destruction, compromised humoral immunity, anemia, and hypercalcemia. It is the most important and common syndrome in the group of plasma cell disorders, characterized primarily by marrow involvement rather than nodal mass. Risk factor. It is having high risk in the age 40 years and above. Gender is more common in males than females. Race incidence is twice as high in African Americans compared to Caucasians. Occupational exposure to petroleum products, woodworkers, and farmers. Peak incidence typically seen in fifth and sixth decades of life. Etiology of myeloma. Radiation. Large dose exposure linked to increased risk with long latent period. Chemical factors. Chronic antigenic stimulation. Exposure to specific chemicals like dioxins, organic solvents. Genetic link. Specific translocations and familial predisposition suggest a multi-step genetic process for transformation. Oncogenesis and growth factors. Growth promoting factors MYC and RAS. Overexpression promotes tumor cells proliferation and survival. TP53 and RB gene mutation in these tumors suppressions are noted in aggressive cases. VLA4 surface adhesion molecules binds myeloma cells to bone marrow stroma. Cell-stroma interaction. Adhesion triggers a massive production of cytokines by fibroblasts and macrophages, creating feedback loop of tumor expansion. The role of cytokines. Interleukin 6. Primary growth factor for myeloma cells levels correlate with disease activity and prognosis. VEGF promotes angiogenesis with the marrow, facilitating the tumor growth and dissection. RANKL upregulated by myeloma cells to stimulate osteoclast activity, leading to bone resorption. Gross pathology. Osseous lesions. Punched out defects. Multiple myeloma typically involves the axial silicon. Radiographically, these appears as punched out lytic defects, usually 1 to 4 cm in diameter. Common site of osseous lesions are skull, ribs, spine, and pelvis. Nature. Gelatinous soft reddish gray tumor masses within the bone marrow cavity. Microscopy. Bone marrow. Cellular hyperplasia takes place. Diagnostic requirement is greater than 10% plasma cells in the marrow. In overt myeloma, these often exceed 30%, appear as solid sheets. Arrangement. Arrangement of cells may scattered or form large cluster and sheets. Morphology. Ranging from mature looking plasma cells to highly atypical plasmablasts. Classic plasma cell features. Nucleus. Round to oval eccentrically placed. Chromatin has a characteristic clock face or cartwheel appearance due to clumps of heterochromatin. Cytoplasm. Deeply basophilic due to high RNA content. Features of prominent perinuclear HOF, also called as Golgi zone. Atypical features. Immature cells shows larger size, lower nucleocytoplasmic ratio, dispersed chromatin, and prominent nucleoli. Binucleotide and multinucleotide forms are common in malignancies. Microscopic variants. Flame cells. Plasma cells with brighted red fiery cytoplasm typically associated with IgA type myeloma. Mott cells. Cells containing numerous grape-like cytoplasmic inclusions called Russell bodies representing immunoglobulin deposits. Inclusions. Russells and Dutcher bodies. Russell bodies. Eosinophilic globular cytoplasmic inclusions. They represent accumulation of synthesized globulins with the endoplasmic reticulum. Dutcher bodies. Intranuclear PAS positive inclusions. Unlike Russell bodies, these are highly specific for neoplastic plasma cell disorders. Peripheral smeral findings. Rolex formation. The high level of M protein reduces the negative charge on RBCs, causing them to stack like coins. ES are markedly elevated due to Rowley's formation. Leukemia. Plasma cell leukemia occurs if plasma cell concentration is greater than 2000 microliter in blood. Clinical presentation. Calcium. Bone resorption by osteoclasts increases the calcium and causes hypercalcemia. In kidney, Benzone proteinuria and light chains leads to myeloma in kidney, or also causes the renal failure. In anemic patient, marrow replacement by plasma cells causes fatigue, pallor, and weakness. Complications of myeloma. Amyloidosis. Systemic deposition of monoclonal light chains as amyloid in heart, liver, kidney, approx in 10% of the cases. Infections. Leading cause of death. Hypoglobinemia makes patients susceptible to encapsulated bacteria. Hyperviscosity. Excessive M protein thicken the blood, leading to visual disturbances and neurological symptoms. Hodgkin lymphoma. Hodgkin lymphoma is a unique B cell malignancy characterized by Reed-Steinberg cells. Is an inflammatory background. Presentation is usually arises in a single lymph node group. Cervical is a common spread. Follows a predictable continuous anatomical order. Bimodal age. Peaks in young adults aged 15 to 35 years aged, and then in older adults greater than 55 years age. The tumor cells, also called Reed-Steinberg cells, usually constitute less than 1% of the total cellular population in the affected node. WHO classification of Hodgkin lymphoma. Nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted. The Reed-Steinberg cell, also it is seen as owl eye appearance, the diagnostic hallmark of classical Hodgkin lymphoma. Nuclei, binucleated or multinucleated with mirror image lobes. Nucleoli, prominent eosinophilic inclusion like nucleoli surrounded by clear halo. Variants of Reed-Steinberg cells. Mononuclear, also known as Hodgkin cells, contain single large nucleus with a prominent nucleolus. Lacunar cells also found in the nodular sclerosis. Cytoplasm retracts during formalin fixation, leaving the cell in lacuna or lake. Mummified. Degenerated cells with pycnotic condensed nuclei and smudged chromatin. Subtypes. Nodular sclerosis. This is the most variant. It is characterized by fibrosis. Brand collagen bands divide into circumference nodules cells. Abundant lacunar variants of Reed-Steinberg cells. Demographics. Slight female predominance involves mediastinum. Mixed cellularity. Microscopy of mixed cellularity is a classical diagnostic. Reed-Steinberg cells are frequent. The background is heterogeneous mix of lymphocytes, plasma cells, eosinophils, and macrophages. Key features are ABV strong association in 70% of the cases. Gender in more common in the males. Prognosis is intermediate between NS and LD. Lymphocyte rich and lymphocyte depletion subtypes. In lymphocyte rich, reactive background consists almost entirely of small lymphocytes. Reed-Steinberg cells are present but infrequent. Excellent prognosis. In lymphocyte depletion, paucity of background lymphocytes, bizarrely leomorphic Reed-Steinberg cells variant predominant upon associated with the HIV and poor prognosis. Nodular lymphocyte predominant. The popcorn cell. Non-classical HL subtype characterized by L and H cells, lymphocytic and histolytic variants. Immunophenotype CD20 plus and CD45 plus, but CD15 is negative and CD30 also negative. Morphology multi-lobed nucleus resembling popcorn kernel. Gross pathology and upper lymph node. Morphological progression initially discrete firm rubbery nodes. Later nodes may become mated and adherent. Cut surface shows characteristically uniform grey-white piece plus appearance. Clinical staging and prognosis. Ann Arbor staging. In stage 1 it shows a single alien region. In stage 2, two regions same side of diagram. Stage 3, both sides are up diagram it shows. Stage 4 shows extranodal involvement in the liver and bone marrow. Prognostic factors. B symptoms are fever, night sweats, weight loss, survival. Modern therapy results in 85% to 90% cure rates for early stages. Thank you.